Okay, today we're going to be discussing the Unit 4 case connections by myself, Joelle Shawan. The date today is December 4, 2024. Okay, we'll be discussing case number 1 first. The patient is a newborn girl and she has symptoms of lethargy, hypothermia, and apnea, and this has been developed within her first 24 hours. She has done blood work and was presented with these ranges. This is her patient chart. Her blood ammonia is 314 and it has increased to 600, which is definitely not normal. The normal is 17 to 80, so you can see there is a quite increase in elevation. Okay, so we're going to be discussing the ammonia transfer and the importance of excretion of ammonia. And we'll be discussing the normal mechanism of ammonia transfer. Ammonia is a toxic byproduct of amino acid metabolism, as well as other nitrogen-containing compounds. It's necessary to transfer ammonia to prevent accumulation and to safely excrete excess nitrogen to maintain the metabolic homeostasis. So since ammonia is a waste product that's normally processed in your liver and removed through urine, through the urea cycle, if it's not excreted, sometimes ammonia could build up in your blood, which can cause many problems such as liver failure and kidney failure. And as you can see from the patient chart, she has elevated levels of blood ammonia. So that means it's not being safely excreted and there has been an accumulation. So here's how ammonia is transferred within these cycles. The first two are the most common in most tissues and liver, and then we'll be discussing the third route for transamination in just a bit. So here's how ammonia is transferred. An enzyme called glutamate dehydrogenase, it converts ammonia and alpha-ketoglutarate, and it turns them into glutamate, which as you can see right here is in the first column. Glutamate is entering within most tissues. Glutamine synthetase, which is another enzyme, it allows the packaging of glutamate and ammonia to form glutamine, which is right here. And this safely carries ammonia throughout the blood where it travels from the blood to the liver so that ammonia could be excreted. So as you can see right here, it is entering the liver. Once glutamine has reached the liver, ammonia is released and it's sent into the urea cycle. And this is facilitated by the enzyme glutaminase. So this is not the only way ammonia is freed. Another process, as I just said, which is the third option, called transamination. And this can occur and take a different route, shuttling nitrogen through the tissues or the muscles. Transaminase, which is another enzyme, it allows ammonia to be transferred to pyruvate, which is normally a product that produces glucose for energy, and it makes the amino alanine right over here. Alanine then carries ammonia into the liver, and through this, we could see the connection of nitrogen transport and gluconeogenesis in the fasted state. So the fasted state is basically where we have not eaten for a certain amount of time. So our body is fasting. When alanine that has been produced through transamination, which is right over here, has occurred, it donates its amino group to alpha-ketoglutarate, and glutamate and pyruvate are formed. So this is the pyruvate that's formed and it turns into glucose, which is used for energy. So as we know that pyruvate produces glucose, but this is done via gluconeogenesis. And when our body is fasting, our body needs glucose, which is that energy. So pyruvate can act through gluconeogenesis to start making glucose from non-carbohydrate sources, such as the amino acids that we just discussed, like alanine. So that's how we can see the connection of the two. And again, it's necessary to transfer the ammonia and excrete it to maintain metabolic homeostasis. Okay, which enzymes are most deficient and which are least impaired? So upon further analysis of the patient, it was determined that her urine orotic acid levels are elevated and plasma citrulline levels are normal. And we'll be discussing what these mean in just a bit. But This is citrulline, which has been determined that her levels are normal, and her orotic acid levels have been elevated. So what urea cycle enzyme is most efficient in this case? It has been determined to be OTC, which is ornithine transcarbamylase. And there's just an error right here. It should be OTC, not OTH. What does it do? It causes carbamoyl phosphate to accumulate, which leads to the elevated orotic acid levels. This is carbamoyl phosphate. As you can see, it has been elevated, so it's no longer making citrulline, which is why it's not being converted to citrulline. That's why the levels are normal for citrulline. It's actually building up, so it's leading to orotic acid. The least likely impaired is arginase, which is right over here. Since this enzyme acts downstream in the cycle and the normal levels and the citrulline levels are normal, it suggests that arginase has converted arginine to urea for excretion, and it wouldn't have affected the buildup of orotic acid levels. Whoops. Okay. What is the essential amino of the cycle? It's arginine, and it's arginine because due to the OTC deficiency, it would indicate that arginine is low. And since it's synthesized in the urea cycle, deficiency in OTC affects its production. So supplementing more arginine would actually help provide a substrate for the nitrogen excretion, and this will continue the cycle. So it's very important because it provides that substrate. Okay, now we're going to be discussing case number 4. This patient is a 58-year-old woman who has been admitted into the emergency department. Here are her symptoms. She has normal vitals, pale conjunctiva, beefy red tongue. She's out of breath when she's walking, for several blocks, as she's mentioned. Unbalanced, low hematocrit level, and from these symptoms, it was determined that she has megaloblastic anemia. So she has actually many symptoms. So I kind of just summarized them into the slide, but for instance, she also has mild diarrhea. She has numbness and tingling of her lower extremities, and as I said, she's had loss of balance. She's had many examinations. She had a physical, head and neck examination, a cardiac examination, neurological, and so forth. So let's break this down. This is her patient chart. She has a tachycardiac number of 110, which is a little elevated, a regular rhythm, which is good, grade 2 out of 6, but she does have a systolic murmur, which is pretty slight, but okay. So what is megaloblastic anemia? Well, it's been determined that she has this because it correlates to low iron deficiency and from the lack of oxygen being carried from the blood, and this is why she has those low hematocrit levels. But let's first talk about what is it. It occurs from deficiencies in folic acid and vitamin B12, which can be due to malnutrition. It also means that without enough vitamin B12, the body is producing abnormal cells called megaloblasts. And as you can see, they're right here. They are enlarged. So this is a comparison from normal to having the megaloblastic anemia. You're having hypersegmented neutrophils as well. So with having these abnormal cells, the megaloblasts, they don't divide and reproduce like healthy cells do. And with these combined factors, the reduced number of red blood cells can actually cause anemia. And without treatment, the lack of vitamin B12 can also contribute to neurological issues, as mentioned in the patient's symptoms, which is the low hematocrit level again, and as well as memory loss. And this was suspected because when the patient told the specialist that she denies any of her neurological symptoms, you can kind of see like maybe she's forgotten or they're not apparent to her, but through the examinations, it was determined. And lastly, the tingling in arms and legs also correlates to a vitamin B12 deficiency. And what causes the deficiency? Again, it's from malnutrition, which is lack of meats, fish, eggs, dairy products, veggies, which are all essential for a healthy diet. Or she has an enzyme that won't allow her to absorb the vitamin itself. So, in conclusion, I can efficiently determine that the patient has a deficiency in vitamin B12. Here are all the symptoms that correlate to hers: dizziness, rapid heartbeat, fingers and hands numbness and tingling, her balance problems, her muscle fatigue when she walks, and headaches. Here are the other two options and why they are incorrect, or, well, not incorrect, but why they're not a good option, which correlate to the symptoms. The first is B6. It can't be B6 because although B6 is important for hemoglobin production, it does not lead to anemia. So we definitely know that she has anemia, megaloblastic anemia. So B6 doesn't lead to that, so it cannot be. It also causes depression and seizures, which were not found in her examinations. It actually has been determined, which I didn't list because there was a lot of symptoms, but she definitely does not have depression. The second one is iron deficiency. Iron is also essential for hemoglobin production and oxygen transport, but its symptoms can include fatigue and shortness of breath, which also correlate, but the findings of beefy red tongue oppose the iron deficiency. Having a beefy red tongue means that she does have iron. Her tongue is still red, so it's not lacking oxygen. And as well as anemia, does not lead to anemia. So therefore, vitamin B12 deficiency best correlates with the patient's symptoms. All right, that's the end of the presentation. Thanks for watching.